This episode is sponsored by PAX, the gold standard in emergency response bags. So when you're working under pressure, you need kit to be both dependable, tough and intuitive, and that's exactly what you get with PAX. Every bag is handcrafted by expert tailors who understand the demands of personal care, from the high-tech, skin-friendly and environmentally responsible materials to the cutting-edge welding process that reduces seams and makes cleaning easier. PAX absolutely puts performance first. They've partnered with 3M to make perfect reflective surfaces for better visibility, and bright grey interior makes finding kit effortless and fast even in low light. With over 200 designs, PAX bags are made to suit your role, your needs and your environment. And thanks to their modular system, many bags work seamlessly together no matter the setup. PAX doesn't chase trends, their designs stay consistent, so once you know one, you know them all. And if your bag ever takes a beating, their in-house repair team will bring it back to life. PAX are built to perform, made to last. Learn more at pax.bags.com or head to the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. Today we're looking at a vision for emergency medicine in the community with Tony Joy. So we're really going to just dissect and unpack what is a quietly transformative movement, which is fundamentally reshaping urgent and emergency care, that of community emergency medicine or CEM. So as pressures on emergency departments continue to rise, and ambulance queues grow longer, a different approach is emerging, one that meets patients' needs where they are, delivering timely expert care in the homes, community and care settings. So at the forefront of this shift has been Dr. Tony Joy, a consultant in emergency medicine and the leading advocate for CEM. With a career rooted in both emergency medicine and pre-hospital care, Tony brings a unique systems perspective on how we can work to increase the provision of emergency care in the community. So it really fundamentally helps improve patient care whilst reducing unnecessary conveyance to emergency departments, but also supports community-based pathways and working collaboratively across boundaries to deliver safer, smarter care. So in this conversation, we're going to explore what CEM really is, what problems it seeks to resolve, and the cultural and clinical mindset shift required to do it well. We're also going to look at risk, governance, innovation, and the practicalities of delivering care outside of traditional walls. So this episode really offers a compelling look at how the future might look more closer to home than we think. Welcome to the podcast, Tony.
Owen, it's lovely to see you. Thanks very much for having me on the podcast.
It's great to have you with us, actually. So just as we start, Tony, I think we want to really have a wide-ranging conversation and really weave in both your experience now, but also your experience prior to now, which is really around community emergency medicine. And for those unfamiliar with the concept, could I get you to describe the core aims of community emergency medicine and indeed the philosophy of CEM?
Yeah, of course. Thank you. So, we started talking about community emergency medicine as what we were doing after we sort of started doing it in about sort of 2015, 16. And this was after I'd been involved with the London Physician Response Unit service. I doubt we were the first people to kind of coin that phrase, but it sort of cottoned on to us that it seemed to fit with what we were trying to do. And operationally, what we were doing was taking a team of trained doctors and ambulance clinicians out into the community responding to emergency calls, trying to interface really closely with the ambulance service, but take secondary emergency care decision makers into that space as well. And that was what the operational model was, and that's developed and evolved and matured plenty since then. But I think it felt like it was a worthwhile endeavor because we were increasingly familiar that patients with emergency needs were not really having those met. And they were not having them met because of the complexities of the system within which they were trying to navigate and access emergency care. And so we thought that this model took things more directly to the heart of the problem, and actually seeing patients in their home or in the community, in their workplace and so forth, created a new opportunity which was simply not there if you saw patients in the emergency department. It gave you an opportunity before the trajectory had been set to try to identify what their needs were, and address them. And that was sort of in a nutshell what we tried to do. I think there was something quite profound about seeing patients so much earlier in the journey, where we could really say, what is the emergency problem? What does help look like to you, this patient? And how can we, as a team that's equipped, experienced, empowered, identify how we respond and provide that help. And it doesn't always mean this patient will be better off in an emergency department or in a hospital. It doesn't always mean this patient will require specific investigations, tests, or interventions and treatments, but often it might. And we try to sort of build in the opportunity to deliver as much, medicine as possible, in situ. But it was so much more about the conversation and recognizing the inadequacies of the wider system. And I would never say this was about, you know, doing more as doctors over other types of clinicians. This was about empowered clinicians, regardless of their sort of clinical background, being able to deploy their skills in a system where we said it doesn't really matter where you're trying to do it. It's more about what you are trying to do. And there've been a few sort of phrases which have naturally caught on since, which we haven't coined, but the idea of right care in the right place first time is a popular phrase often used in sort of National Health Service policy and so forth. But that's exactly, speaks to what we're trying to do. We recognized that patients were trapped in complex systems and that pushed them further into a system, perhaps because of a difficult ability to tolerate risk, because of skill sets and training and process and safety mechanisms and so forth. But patients got pushed further and further into a system where it took many steps before actually they would see a senior decision maker who was able to sort of sometimes just call a spade and try to identify what the need is. And if they're so far into the system, there's a lot of inevitability about what then happens, what then plays out, the thresholds for instance, admission to hospital, the thresholds for different types of investigations and that sort of thing. So it was pulling it all back. And I got involved in community emergency medicine a long time after it had really started. The London model preceded my involvement by a good 15 years or so. And I think the sort of the philosophy had developed, but it was always about trying to take senior decision makers into the patient journey far, far earlier.
And I think that's powerful as a shift, Tony, because to your point, it's far more patient-centric when there's an active pivot of listening, but then, as you were saying, almost making, cutting down on any gaps, and getting to that senior decision making. So let's just articulate the gaps, if that's okay, Tony, and maybe really get you to speak to really what gaps in patient care or system functions and or utilization of pathways did or does community emergency medicine seek to address? And indeed, it, could you speak to the evolution and how that it's even closing the gaps even further in the contemporary environment?
Yeah, sure. So, you know, urgent and emergency care systems have been designed to deliver healthcare at scale. And ambulance service control rooms, EDs, and their front doors are busy sources. The amount of input is huge. So they do need mechanisms to manage things at scale. But one of the consequences of that is the need to be quite generic sometimes. The need to be quite d deliver mechanisms that are quite risk averse. And that doesn't serve all patients well. It serves the mass in a safe way. But as I've already described, it sort of pushes patients through the system quite often. Um, so a big part of this, I think, is about where is risk held and who is prepared to hold risk. And I think many sort of service users and patients, as well as healthcare professionals, would recognize the sort of the common frustrations of well, I'm not sure this patient is best served in the setting that I'm seeing them, but this is where they are. I am the person that is being asked to see them, and whether that might be an ambulance crew who's been dispatched to see a patient who might have tried to access their GP and perhaps found that difficult, or might not have tried to access their GP, might have phoned the 111 system, and the 111 processes and pathways have dictated that the outcome of that is best served by an ambulance dispatch. And then the ambulance clinicians um, will be able to make their assessment, but might not feel empowered within their scope of practice to make a decision other than to convey the patient to hospital. And then in hospitals, because of the complexity of crowded front doors and so forth, often what happens first is batch testing, batch investigations to try and gain time later on. So front loading investigations so that when patients have their definitive assessment, they're sort of informed by that. But so it becomes normal to do these things rather than saying up front what actually this person in front of me who's asking for help and has defined their need as an emergency need, what is the most appropriate thing for them, and can we make that decision about what we will do earlier on? So I guess that's the sort of the opportunity of Chem to try and front load all of that. In terms of gaps, I mean, we've recognized that access to primary care and access to emergency care has got frustrations for patients. But we have medicalized society over the last 2 or 3 decades. We have invited and encouraged patients to seek help for a full range of sort of presentations. And if you take something like a rash in a child, we are very aware that most rashes in children might be very mild, might be very trivial, but we've also encouraged new parents to be really observant for, a purpuric rash that could be the first sign of a meningococcal illness, or as another example, chest pain. We've had big posters on the sides of buses and on tube trains and things saying, if this is your symptom, call for help, and that's absolutely appropriate. This public health messaging is essential to try and save lives ultimately, but we aren't asking the public to make those decisions about what is a really serious cause of chest pain that requires investigation and might be an acute coronary um, syndrome, or it might be a really trivial cause of the symptom. So it's never that I don't think it's ever the patient's fault that they're seeking help, and we shouldn't be frustrated with patients for accessing our emergency systems, but we do need to give a proportionate response, which is sort of targeted to the specific needs of the patient in front of us. I think there's also something that's worth calling out, which is around patient anxiety, which has emerged in the last few years, particularly since the pandemic. And actually, going to hospital, perhaps a few years ago, felt like what patients wanted to do because that's where they felt that the sort of the investigations and the care that they felt they might need would be found. Patients are quite afraid of the hospital setting now, and they know that the experience currently in the pressures of the current National Health Service in the UK is that they will expect long waits. They might expect to have quite a disappointing experience, even though the care that they ultimately receive and the decisions are hopefully to a really excellent standard. But there's a lot of people that are afraid to do that, and even though they need help, they don't actually want to go to hospital, and they often refuse to be conveyed to hospital, for instance, and that creates a gap. That creates an equity gap, and I think we've got a responsibility as a profession to ensure that that gap is met, and that we still provide the least restrictive care to these patients for whom actually it's quite difficult to ensure they have access to secondary emergency care.
So looking at the gaps that Chem really serves, because there is in a way, a blurring between the traditional lines of emergency, primary, and urgent care, and it's a shift. Tony, really, in the clinician's mindset and skill set in the field. Could I get you to speak to that shift, that mindset shift between Like you say, sort of bridging that gap really, because it's meeting the patient earlier on, as you were saying before, in their journey. But could I get you to when you're working with other clinicians and bringing other clinicians along on that journey, could I get you to speak to really, yeah, I guess in a way, reframing their mental models about bringing that care closer, that, closing the gap, because so much of emergency care is urgent and primary care. So much of what you see in ED in that waiting room is primary care, and so the gap that's closed in the community, but is almost bringing clinicians closer to that patient rather than in the ED in their home. But it is a journey for clinicians as well. Could I get you to speak to that journey?
Yeah. And I mean, it's a fascinating challenge to try to discuss, isn't it? And I guess perhaps the thing to throw back is how well have we really defined emergency care and urgent care and primary care, and how much variation is that is there around that in the different systems, around the world, around Europe, and even around the UK, because it depends frankly, it depends what the time of day is. It depends where the patient lives. It depends on their age and other factors, the languages that they speak, and it depends on the nature of the presentation. And going back to chest pain as the example, GPs see so many patients with chest pain, and probably manage far more than any other clinician in the system, in a community setting. Um, but if the patient has chosen to access healthcare in another route, then actually it sort of tips sometimes into another direction. And I don't think, therefore, we're able to say there's any such thing as a primary care patient or an urgent care patient or an emergency care patient. It's that there's a huge number of variables that make that, well, as you say, the lines are very blurred. I think there's there's something about the clinician's mindset, therefore, and having good understanding of the wider system. And I think what we hoped we were achieving, and the chem model in London, and certainly in chem services elsewhere around the UK, is giving clinicians insights into the wider parts of the system. So, for instance, giving clinicians that might normally work on the ambulance service really good insights into what secondary care pathways look like, which patients actually come into hospital and get admitted when they present with this kind of abdominal pain or this kind of a head injury, which patients actually get a scan, and actually get further investigations, and vice versa, having hospital-based clinicians having a chance to see patients in their home is such an eye-opener, and completely reframes the clinical consultation and brings in new elements to it that you would probably not really think about if most of your practice is in hospital. But you'll be too aware of this, Owen. But when you're in a patient's home, and actually what you want to do is stand up and go and have a look in the fridge to see whether that gives you some insights into, is this quite frail person actually able to look after themselves? Are they feeding themselves? To get a sense of you know um, how tidy or how cluttered spaces are. Whether someone's knocking on the door asking if they're okay because they've seen an ambulance outside, or whether they seem very socially isolated. And this stuff gives you really golden information about actually how patients are able to support themselves or be supported within their community, for social support and so forth, which in the frail population is gold dust kind of information. So I think walking in the shoes of other clinicians and understanding the wider parts of the system is a big part of this opportunity as well.
Listen, I would agree with that, Tony. And I think to your point about knowing the patient journey and then understanding what the ceiling of care and or the ceiling of monitoring or intervention and or testing would be in the next level allows and informs you as to early on in the trajectory how to steer the patient forward. But talk about risk more, if you would, Tony, because we've notioned towards it so far, and there is an element of holding risk earlier on in the patient journey. Could I get you to sort of speak to that?
Yeah. And it's a fundamental sort of construct that perhaps modern healthcare systems, I think, are grappling with, and sometimes quite clumsily. We in the way I've described, we probably don't hold risk. We often push it further down and ask downstream parts of the system to take it. And what that often means is the sort of dialogue which goes, well, you've got this problem, so we need to do this. So therefore, I'll need to take you to hospital, or I'm going to need to admit you to hospital because we need to keep an eye on you for some time, and that sort of thing. But we don't really, I think, often truly inform patients of the sort of the counterfactual there, and what the what the risks of doing that are. And we've got plenty of data now to support the harms of waiting in emergency departments, the harms of being hospitalized for a few days or longer. But we don't really consent patients for that, do we? We don't really sort of say, well, one option is that we do these things because sometimes with the presentation that you've got, this is what we might do. But if we do that, we'd also need to expose you to this potential harm. That's not really part of the discussion that often happens, and that's because the trajectory has already been set. And actually, to pull patients back along the trajectory takes really active energy, which I think is very hard for clinicians downstream to do. So I think we need to just be much more open about talking about risk in a balanced way. On the London Physician Response Unit, we actually had a a written SOP called Understanding Risk and Our Values, and it was overt in stating the complexity of the decision making in the environment and encouraging clinicians to gauge their own, sort of involvement in those decisions, their level of comfort in those decisions, and talk about it and really externalize it. I think there's another really fundamental point around actually what the core components of evidence-based medicine are. And clinical judgment is one. So that's about clinicians that are empowered, experienced, trained to deal with the clinical scenario that they're faced with. Then there's relevant science, and that's about knowledge of current literature, current data, best practice, and so forth as we see it. But the third core component is about patient values and preferences. And you're not delivering evidence-based medicine unless you incorporate all three components. So patients should be involved in decisions about their care as well. Um, and I hope it doesn't make me sound like I don't think patients with emergency problems need to be investigated, treated, and they absolutely do. But they need to have that done in the right way, in the proportionate way. And sometimes that's in hospital, sometimes that's out of hospital. It doesn't really matter where it is. It just needs to happen.
So, could I get you to really speak to just the integration with other community-based services? Having been on the physician response unit myself back in 2007 to 2009, it was a revelation to me to see how integrated and how, to your point, getting to the fundamental diagnosis or indeed the problem set, and then offsetting that and the integration with other GPs and just a referral to a GP service or an out of hours service or a social care team could alleviate a whole chain of events. But to your point, mainly for the patient. But could I get you to speak to really that interface and indeed that continuity of care to fundamentally avoid duplication of
Yeah.
testing and of handover?
Yeah, and exactly to avoid duplication, and also just to create a safety net. The decision that we might make for a patient today might change tomorrow. We can use time as a test sometimes to see if it's the right thing, and recognizing that patients' trajectories, as in their clinical trajectory, might be an improving one or a deteriorating one. But in the position you find yourself as a clinician with somebody for an hour or so, you don't necessarily have a sense of the gradient of or direction of that. So you do need integrated care structures to enable safe practice in the community. Otherwise, as we've kind of already identified, the default might be, well, it might be safer to keep you in hospital for a few days so that we know you're going to be okay, that sort of thing. So what does integrated care structures really look like? Well, maybe 15, 20 years ago, it was much more piecemeal, and there were GP surgeries which be open in daytime hours, and then there was the hospital, but relatively a bit less in the community setting. But actually, over the last few years, there's been a real emergence of urgent community response teams, like rapid response nursing teams, who are able to deal with a lot of this on a primary basis, actually, and often deliver a really timely response for lots of different needs in the community. And so we always found that building a strong relationship with those teams in London really helped propel the sort of the ability to provide a good safety net and manage a bit more risk in the community. So we worked hard on building trust and confidence between the two services so that we could kind of mutually work really well together. There's also been the emergence of virtual wards over the last few years. So caseload of patients being managed virtually in the community, usually with secondary care and primary care clinicians involved, and the possibility of remote monitoring, the possibility of visiting patients on a daily or a two daily basis, and providing support in that sort of way. Um, and 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 there is much more. And there's hot clinics in hospital, same day emergency care, but that can often be arranged for the next day as well. Um, and um, and actually telehealth. So being able to provide a video consultation the next day or something like that to check in on somebody might be really appropriate. We built up a sort of a bespoke directory of services, which was a very empowering tool for the clinicians, which was more than the kind of um, the other directories that have been made available at a sort of regional level. This was our own, local intel, people that we could phone, pathways that we could access because we knew in this hospital that there was a really proactive team in, let's say, diabetes management, so that actually we could often offer a sort of a next day opportunity to speak to a diabetes specialist nurse for a patient with a diabetic emergency, but actually and that was enough of a safety net or and that sort of thing. So we created our own directory of services, and then that scaled up as we also launched a service which provided more remote conversation support to ambulance crews in the region to help do sort of clinical care coordination with a discussion with a consultant, speaking to crews at sea, and actually that directory of services really underpinned that evolution as well. So yeah, I think it's about identifying what's there, mapping it all out, and then building confidence and building trust in what those pathways are. So that I think a lot of the anxiety about referrals has often been sort of either not very much confidence in who is making the referral, so therefore the inclination is to say, well, I can't do this. It feels a bit risky for me to take this because I don't have confidence that you are trained, experienced, skilled to say that that's the right thing, and then it puts the risk into my court, or they sort of feel like they're at capacity and don't communicate that very clearly. And if you're trying to make a referral, you need to know it's made. There's no use for ambulance crews at scene or doctors in the emergency department saying, "Well, look, I'm gonna leave you here. I'm gonna let you go home, but hopefully this team is going to come and see you tomorrow." If you don't get confirmation that that referral is made, then actually you have no confidence, and again you default to the sort of the standard, which is admit the patient to hospital.
Yeah, indeed, indeed. And I think to your point around building trust, building confidence and building awareness. And Tony, you could speak to this, even just the soft skills of going to see teams on on days off or on maybe on admin days where you can introduce the service, you can put a face to a name, and then actually when you call that person or you call the team, there's already a rapport built, and they can visualize you, or indeed they visualize the service, and it's those soft skills and those soft relationships which actually build bridges and build trust and rapport, and never negate the power of relationship in these regards.
It's so true, isn't it? And there's been a lot of efficiency developed into healthcare systems in recent years, but perhaps one thing that has been lost a little bit is the mess room kind of uh, social opportunity, which was also a professional opportunity to create a network and like you say, sort of create sort of rapport, so that you could exploit that network, and advocate for your patients by having the opportunity to do that rather than just send a sort of nondescript electronic link, hoping that it's a referral successfully made, but the likelihood is that there might not be because the systems don't trust who's making it.
So listen, my next question really, it was and is quite a simple one around the power of active listening, and let's go there. But what I'd actually like to do is just increase the valence and maybe the scope of the question. That is, the power of active listening, putting patient first within community emergency medicine. But now in your current role as the medical director of what is a critical care service within Essex and Hertfordshire Ambulance, having the same power and tendency to have an active listening lens for clinicians who are then going to treat probably the sickest patients of the day, month, or year. It's the same skill, very different context, but equally as powerful. Could you get you to sort of really unpack it?
Yeah. It's so important, isn't it, that we remember as clinicians that our patients are people, and that regardless of the situation that we find them, their experience of the care that they're receiving is sort of foremost in our thoughts. Um, like I've said before, patients need our help, and it's for us to provide it regardless of where they are, how unwell they are. And our systems need to ensure that the environmental bits are sort of don't create a detriment to the quality of care that they receive. So in the critical care setting, we need to be absolutely steadfast in our sort of training for rigorous clinical standards, in spite of the complexity of the environment, be that in a wet and greasy road in the depths of winter, in a sort of a road traffic collision, or under a train, or in a stairwell, managing a sort of complex cardiac arrest with no space. All of those sorts of things are environmental factors, but the clinical aims, ambitions, and targets need to be actually what we focus on in terms of improving patient outcomes. Now, the patient perception of their outcome is perhaps less of an immediate priority in the trying to restart a heart phase of critical care. But in terms of supporting them through their journey of recovery, actually what they recall of the care that they have had, how they have felt communicated with, how they've felt supported in their journey of recovery and rehabilitation, I think has got a direct bearing on how they ultimately, recover, resume their normal life, hopefully, and get back to good function. And so there's a long, protracted phase of care where the patient needs to be absolutely listened to. Um, and I guess that um, what we want is our clinicians to feel like they've got two roles. One is a technical, clinically orientated role, which is about deploying the best interventions to improve the sort of physiological outcomes. And then the second role is around communication, overt display of compassion and humanity to patients and their families, so that the sort of the overall response is that people feel really wrapped up into a supportive healthcare system, which is there to address their needs.
Yeah, indeed. No, indeed. Tony, could I get you to another question, really, which bridges both your past and current roles, really is governance. And could I get you to really maybe unpack how governance is a central piece in safe care, but also scalable care models, and that sense of accountability in maybe an acute and or primary care setting, but also certainly within a critical care setting. Just that sense of accountability, transparency, and understanding decisions and how we make decisions.
Yeah. And this is difficult depending on the pressure, of the day-to-day sort of operational pressures of different systems permit different levels of sort of time and headspace, I think, don't they, to deploy what you would say were good governance standards, and recognize that for many NHS organizations, governance can look quite piecemeal compared to, for instance, many of the HEM services around the country, where actually there more space is created to be able to discuss in depth patient episodes. But I think that is the critical opportunity, is to create space for reflection, for debrief, for vulnerability, for openness about the idea that you can learn something from every single patient encounter. You can learn something from every clinician that is talking about a patient that they have seen that you haven't seen, by really trying to be empathetic and understand the elements that they wrangled with in their decision making and in their assessment of the situation. And what we really need is, adaptive systems which enable that that listening and that learning, that sort of collective vulnerability, and the willingness to say, we can always think of something that we might have done differently, and for our next patients we want to make sure that we're learning from the patients that have gone before, and sometimes that is about closing the loop on phases of the care that we weren't necessarily involved with. So for a HEM service that has taken a patient to hospital on the critically injured patient who's given the impression that, on examination and according to mechanism and so forth, that they were, let's say, bleeding to death from intra-abdominal bleeding after an RTC, and being treated accordingly. But actually, if we don't close the loop on identifying actually what were the findings in hospital, what was on that CT scan, what was the operation that they required or didn't require, how much blood was given in hospital, and what was their sort of subsequent outcome and recovery looking like. If we're blind to that, then we're sort of stuck in a cycle of failing to learn. And the same is exactly true for patients that die. If we fail to close the loop on what was the cause of death, what was found on the post-mortem, and was that post-mortem performed in a rigorous way that we find those findings really useful? How do we communicate that back to our team? How do we feed that information in a sensitive and facilitated way, so that it's not about uncovering all the things that we should have done. It's about recognizing the complexity of providing care in that setting, and then enabling maximal learning. And we call that process clinico-pathological correlation. And colleagues at the Essex and Herts Air Ambulance have really tried to bring that into the mainstay of our governance processes in order to maximize our day-to-day learning from everything, from every patient encounter. We also really try to bring the patients back, where possible later on, to talk about their experiences and actually enable them to be faculty on our courses, to help design scenarios, to talk about, what was their experience of care. And actually, this was what was important to me. I know you're saying that I'm stuck at the bottom of this stairwell, and that you want to address A, B, and C and all these clinical priorities, but I'm really cold, and I'm in a lot of pain, and those are the things that I remember. So please, can we address those things, please, as well? And I think that's how we mature as a system, isn't it? By bringing all those inputs together.
Yeah, absolutely. And to your point, actually, that patient pillar, that third pillar of patient care and patient preference and patient voice is so important. But just flipping that question slightly, Tony, and looking at community emergency medicine and how you manage and, to your earlier point, hold risk by reaching into diagnostic tests within prior patient consultation. One of the fantastic care episodes and indeed scenarios I witnessed when I was working on the physician response unit was that colleagues, GP colleagues, would reach back into prior testing or indeed prior ECG or indeed other diagnostics and let that inform current presentations or indeed and that wouldn't necessarily just be from referral pathways. That would be from GP colleagues, that might be from community outreach teams, and starting to get other tests, other diagnostics, other findings to inform current presentation, and actually, so you're not blind, and you're starting to, in essence, to your point, do what you're doing within the emergency department, just in the community, where he's resourcing other people, other diagnostic tests to then bring to bear what might be a very similar diagnosis, or indeed a very similar trajectory. Could I get you to speak to getting resourcing the community to inform a community-based consultation?
Yeah, I think I think the key point here is you know a healthcare episode is not a snapshot. It can't be most safely managed if you're not informed by by the maximum information that's available about a patient. And we're now supported by digital, systems that enable, for instance, on the physician response unit, you can just log into the electronic health record, so you can look at previous, blood test results, ECGs, and clinic letters, and all of that sort of thing that are available on on the wider hospital system. But actually, that's not, frankly, good enough. Actually, I think at a sort of societal level, it's not really acceptable that all of the information isn't available to all clinicians at all times. Although I would add the caveat that the clinicians need to be able to interpret that accurately and put it into the right context. So there's a lot of training and experience and so forth, to sort of maximize that opportunity. But we are moving into a situation now where very often clinicians will have good access to what has gone before, and actually be able to see as well what might be coming down the track in terms of planned investigations or planned clinic appointments and things like that. So there's a sort of security and safety element to that. I think, and actually the same is true in the critical care setting. Having access to the summary care record and the NHS, just to be able to identify if there's an unconscious person, being able to identify if they've got a complex medical history, what medications they might be on, if they've got some other background information that's really relevant to that. We should empower our clinicians to have. Otherwise, you're sort of sending them in as a blunt instrument rather than a sharpened toolbox with all these things, which may or may not be useful on day to day, but sometimes will certainly be very useful.
So let's just quickly talk to that training piece, actually, if that's all right, Tony. It's not a quick answer because it is probably a very much comprehensive and competence-based training program. But could I get you to maybe just initially speak to really that ongoing supervision, support, and training for community emergency medicine?
Yeah, I think when clinicians are used to working in one environment, it's always a steep learning curve to change that. And taking, emergency medicine doctors that are used to working in EDs, and asking them to leave behind their sort of their security blanket, their senior colleagues, their support structures, the opportunity to walk down a corridor and have a little think and speak to somebody and that sort of thing. But actually, just put them in a car with a colleague, then yeah, very steep learning curve, quite overwhelming for people. I think you need to give people the space and time to learn and be supervised in that. So typically we would have between 4 and 8 weeks of sort of supervised practice with a really rigorous and robust training sort of scaffold behind that around you need to be prepared for these scenarios. You need to be really familiar with these standard operating procedures. You need to really demonstrate that you know how to troubleshoot all of this equipment because there's no one here to bail you out, and it won't be safe otherwise. And the team membership, the team followership, the team dynamic is therefore essential in that as well. So the CRM, the communication, the documentation, all of these things come into that training and supervision phase. And I think, on the clinical scenarios bit, it's very unfair to say to somebody, look, we're trusting in you, we're empowering you to manage a complex post-ROSC cardiac arrest scenario where you're going to be called and actually you're going to have to deliver well, your decision making around an anesthetic. Do you need to deliver an anesthetic? Do you need to not? Is one example there. But another one is um, you're in a room with some very emotional relatives, and there's a patient with dealing with complex frailty and likely an irrecoverable illness. But their expectations are, and the family's expectations are, that you're going to make them better. How do you manage the sort of communicative complexity, the sensitivity? How do you actually do you apply a sort of almost like a checklist into that situation to navigate it with maximum empathy and ensure that questions are answered and you're providing the most holistic care. So that and I think the thing about chem is that there is the full breadth of care provided, and I would argue sometimes that it's therefore far more complex than just focusing on critical care because you know there is so much breadth in the sort of caseload and the decision making is where all the nuance is, and there's very little that you can sort of map out in terms of process for some of these complex, very nuanced, very individualized situations. There's a caseload that is probably worth mentioning where there hasn't been equitable access to emergency care for the learning disabilities population. Very often, really, sometimes when behavioral complexity has meant that patients with learning disability have not been able to gain access even to primary care, but take for example, dentistry often becomes a really significant medical problem for a very young population because of that factor. And the physician response unit has done a lot of work to try to address that inequity, and has created a sort of pathway, a sort of planned pathway to help go into people's homes with some pre-planning, offer oral sedation in a sort of calm setting, and then actually take patients for essential care, or deliver it in situ, and then wake them up and it's hugely compassionate, really complex though. And when you think about the risk question there, it needs to be held very carefully and at the forefront of your mind about what is appropriate. But that's an example of what quite a complex training need, where you need to create the space to ensure that clinicians are comfortable, competent, but also then empowered and supported to get on and deliver.
So just mindful of time, just rolling two questions into one, really, Tony. One would be the future of chem and how you envisage the future of chem looking, but and also if someone wanted to get involved, really to champion chem and sees gaps maybe within their own service, could I get you to sort of speak to those?
Yeah, of course. I mean, I think chem is There's probably very many different guises. This is about ultimately having empowered clinicians who are trained and able to provide emergency care in situ, um, regardless of the environment, and maximize with sort of integrated care structures around them to do that. And so, whether that's more doctors working alongside ambulance services and working more in the community, whether that's further training for the paramedic group to increase the scope of practice and the autonomy and so forth even further. There's so many different directions that this will go. But what is clear is that national policy is going to require more care to be provided in the community and is increasingly going to recognise the harms of hospital, and need us to be much more responsible about the decisions that we make for patients, recognizing that the trajectories that then follow those decisions may incur some harm. So I think it's important to recognize that every decision is significant when it's taken on behalf of a patient, and if even if that decision is simply about conveying a patient to hospital, it comes with a lot of implication and ramification, and we need to be responsible about that. So I think CAM models are likely to develop a lot more, and there's lots of up and down the country of emerging services that are doing this sort of thing. And I think if people want to get involved, then I think that the point is if you're a nurse, a doctor, a paramedic, gain the most experience you can be to be the best clinician that you can, fight for your patients and look for like-minded clinicians that are doing similar things in your systems, at that kind of interface between ambulance service, acute hospital and community. I think what was the second part of your question around?
Getting involved within chem services and indeed just maybe just volunteering or indeed contributing.
Yeah, I think look at your local systems and see what opportunities there are to be involved. But and look at some of the papers that have emerged about chem. Get in touch with some of the authors. It tends to be a sort of a group of very like-minded individuals doing this sort of work and seeking to see it develop. I think there's something about having a mindset that recognizes the current limitations of the system and being a strong advocate for change, being a strong advocate for patient-centered care, and recognizing that the complexity of our systems is not always serving our patient needs, and we need to insist on systems that sort of fit together better, and yeah, really scrutinize all of our decisions along the sort of the patient journey for the point being it's our patients that we're there to serve.
So just finally, as we come into land on the conversation, Tony, really, you're at this intersection, which is fascinating, really, where you've worked across emergency medicine, but also pre-hospital critical care, and indeed community-based emergency medicine. Could I get you to maybe speak and unpack finally for us, really, what unites those areas in terms of values of philosophy, and just some uniting principles, really, that bind those together.
I mean, look, it's an absolute privilege to have had the opportunities that I've had in my career so far, and I feel really yeah, really fortunate to have been able to do the things that I've done. I think I've adopted quite a sort of system lens for quite a few years now, and so I'm a little bit fixated on the sort of the transformation opportunities in the systems, and I think that's partly because we've set up our systems on assumptions that are either dated now and no longer true, or were false all along, but we weren't really able to articulate it. And that works at a clinical level about things that we think work, but actually the data doesn't necessarily follow, and we need to be more rigorous. We need to be better. And like I was saying before, we need to close the loop and get our outcome data to really sort of map accurately whether or not the things we do are for patients' benefits. But I think there's other false assumptions around, how we make decisions about the best way to provide care. The best response being, in a certain part of the system, whether, like you've said, primary care or community care or in an emergency department and that sort of thing. And we should challenge all of those assumptions and be much bolder as we embark in the next decade or two in a very different world, which will be facilitated by digital evolution and new skills developing across the breadth of healthcare professional, the skill mix and So I think the future's really bright. I think the point that I made about, we're here to serve our patients is the thing I continue to sort of try to remember at all times and encourage colleagues to, is that, in spite of the inadequacies, in spite of our own personal ambitions and desire to learn new skills and deploy new things, we need to work as a system to make sure that our patients are getting the best care. That's our responsibility. And perhaps the bit that we've identified is that the sort of the pre-hospital space. So there's critical care providers and there's a few chem services and things, but the pre-hospital space is perhaps sometimes a little bit of a void in terms of senior decision-making support. And I've learned most of my pre-hospital care from a brilliant group of paramedics over the years. So this isn't about doctors and paramedics and that sort of thing, but this is about trying to make sure that all of our decisions are made informed by the most information and by those that are most empowered to make them, and tolerate a little bit of risk, a little bit of uncertainty, and apply a bit of nuance. And so I think by working together as professionals, by integrating our system components, actually that's where the great opportunity lies.
Listen, I agree with that. And I think to your point about having oversight and just, as you say, just someone to be able to speak to, just to be able to pick up the phone, have a bit of reach back, have a bit of clinical oversight with, if that's community emergency medicine or indeed critical care, both are complex in very different ways. But just having two brains are better than one, running a plan by somebody sometimes is just so much more beneficial and actually offsets risk, but also just allows people into that decision making space. And I think it's a powerful pivot in both environments and for both ends of the spectrum. And I think we should encourage that more, having that MDT approach in real time. And to your point, within London and within Essex, having the clinical vulnerability to say, Tony, what do you think? Either on scene in real person, or actually, let me just share this complex decision with somebody just quickly, 30 seconds or a minute. It allows two brains into that same patient. And I wasn't going to say that, but I just really agree with what you're saying there. Just allowing others into that shared decision making. I think it's a powerful pivot, actually.
But I think that's exactly the point. It's what our patients would want us to be doing, isn't it? It's a safety mechanism, and it's us working as advocates for their care. And actually, as clinicians, it makes it more enjoyable. It makes us feel less isolated, and it makes us feel more empowered. So whether you're working for one organization as a EMT or another organization as a consultant or another organization as a community nurse, actually being able to have conversations together which say, this is the problem I'm trying to deal with. This is what I think we ought to do. What do you think? That's what our patients would want us to be doing. So yeah, let's make sure we do.
Listen, it's a privilege to have you on, Tony, and just to get your perspectives, your unique perspectives. Thank you so much for the past hour.
Thanks ever so much, Owen. Really enjoyed it.
You're listening to the Pre Hospital Care podcast on the Medics Academy Network.